that we're going to cover about fragile patients having a threshold where they get cognitive disruption and use primitive defenses. They can take many forms, including masochistic patterns, somatic symptoms, dissociation, and paranoia, and can move between these patterns. Fragmentation of the self, where the person is fragmented into pieces, can make a more complex picture, requiring us to do psychic integration and stabilization in order to be able to begin to get to the point to use graded format. And graded format is these cycles of pressure or bracing plus recap. And the technique of bracing, which I'm going to cover, is a powerful tool when the person's almost at the level of tolerance, the top end of what they can do. Over time, we look to see anxiety go to the voluntary muscles and defenses shift into isolation of affect or ability to self-reflect on emotions. And after that shift, the person can start to experience their unconscious feelings. So we're going to cover all these things. Those are some of the key points. So let's go rid of this here. So to start here, we have attachment. And what I want to start off with here is to show a patient who doesn't have fragility. So you can see what a person looks like who is solid and structural and hasn't had the type of trauma load and the deficits that the more severely fragile patients have had. So they have an attachment that is being interrupted by some sort of interruption of the bond. It can be the death or illness of a parent. It can be neglect or abuse coming from the parent or from others, leading to all these complex feelings: love, fear, pain, rage, and then guilt about the rage, leading to a person who is shut down as in a childhood and adulthood into self-destructive patterns and symptoms and physical symptoms and other things. Those past feelings come up with us, they come up with current people, and they manifest as anxiety that is unconscious and defenses that are unconscious. And the end result is that we sit down with the patient and all these feelings are mobilized with us, showing up with anxiety that you can diagnose and defenses that you can diagnose. Now, when we sit down with a person to help them to solve their problems, it mobilizes complex feelings with us, including positive feelings and irritation with us at the same time. And those mixed feelings go right back to all of these feelings here. Okay. And the end result then is that we're mobilizing these past attachment feelings, which then causes the anxiety and defenses to rise. That allows you to see how their anxiety and defenses work, and that lets you decide what way the treatment needs to look. As you're doing this, mobilizing these feelings from the past, it activates a key healing force in the patient that Davin referred to as the unconscious therapeutic alliance. And that is mobilized. It's a force that brings insights and mental images and linkages to the past trauma. And so it's like the memory system is opening up and bringing these past content forward. So if you put it in a nutshell, we try to engage the person. It brings up their attachment feelings. It causes their memory system to kick in. And when they can feel those feelings come up with us, the memories and emotions come into play. They can experience them and see them and be in contact with their unconscious feelings of the past. That's it in short. So now, there's different steps we take in order to get to do this, though. And the first is to assess whether there's any barriers to engagement. And the barriers to engagement refers to that they're not wanting treatment, they're forced to be there, they have active suicidal ideation, or there's some other thing that consciously is there as an obstacle that needs to be talked about. After that, we can assess what is on the front of the system and do the psychodiagnosis. So the front of the system can be mainly avoided feelings. It can be mainly active defenses. It can be active anxiety, or there may be nothing active on the front. And for each of these, we have different approaches built into the model. And so what we do is we work with the front. In the case of this, for example, we press on the avoided feelings. In the case of the second, we press into the defenses. And in the case of anxiety, we either press up if the anxiety is in muscle tension, or we reduce the anxiety if it's too high. So we work with that, and then we do psychodiagnosis. So psychodiagnosis, we do some pressing onto the feelings or defenses, and we watch the anxiety response. And that tells us the channel of anxiety and the defense patterns that we need to work with. Now, as far as major patterns of resistance or major resistances, the big ones here are isolation of affect, where the person can intellectualize but doesn't feel feelings. That corresponds with anxiety in the muscles, with hand clenching and sighing respirations and a clear head. The next level is the emotions being repressed, going into the smooth muscle of the body, the stomach, the blood vessels, the bladder, and into muscle weakness and depression. So that's when the emotions do not reach consciousness, they just disappear into the body. The third level is primitive defenses, where the person uses splitting, projective processes, split parts, projected parts of self, projective identification. And you see this with cognitive perceptual disruption. So this is the fragile group. Cognitive perceptual disruption, the person can't think clearly, they lose their vision, gets blurry, they have trouble with hearing, they get confused, they can lose consciousness. This is the population we're going to talk about here in this course mainly. And the last category is just resistance of guilt, a need to defeat and sabotage as one of the resistance of the self-punishing drives related to the punitive superego. So we're going to be looking at these categories and patterns here as we go. And you can, when you have, based on your assessment then, is you have the category whether they're low, moderate, or highly resistant, not fragile, or whether they're mild, moderate, or severely fragile. And from that, you have your treatment outlined from that. So before we get to fragile patients, I wanted to just say a word to show a patient who isn't fragile and to look at someone who is similar in age, same gender as the patient we're going to work with, but not fragile. So you can see a similar person, but not having fragility. And this is a person who has moderate resistant, who has murderous rage and guilt in the unconscious. Anxiety is all in striated muscle, there's voluntary muscle tension. Main defenses are intellectualization, isolating affect, high capacity for anxiety tolerance to be able to hold the feelings. And so what do? We first focus and press on underlying feelings. When the person comes in, these patients come in tense almost always. You press, you activate these complex feelings and alliance. Some defenses go up as you go. They start to defend and detach from you. You help them stop detaching. You clarify and challenge that detachment. Then they feel the complex feelings go through the body. They experience them in the body. That results in a drop in anxiety right away. The feelings come through and the anxiety drops. And then the anxiety drops, the defenses drop, and then you have this unconscious alliance up. The person now can remember the past traumas that are there, and these linked content comes to mind. the person can calmly face some of these trauma. So that's it in a nutshell with a moderate resistant patient. And so what are these interventions and how do we go about these? I'm going to describe that with this case here. And let's see here. So we're going to see this process here with some video in a minute here. So just to say a word about the main interventions we use. Pressure is to encourage healthy actions, to encourage the person to do something good, to identify their problems, to work with you, to be present, to feel things, to talk about things, to remember things. These are all pressure interventions. You're trying to connect to the person stuck behind the defenses when you use pressure. So an example of pressure is asking how the person feels, asking what feelings feel like in the body, asking them to be specific, to be present, to be active, to be self-caring. And pressure, we want to be pressing on the front of the system, the way the person is interfacing with us. If they're avoiding feelings, we want to press on the feelings. If they're defending, we want to press into the defenses for them to not defend. And when they start to heavily defend in a room, then we have to do other things, which is clarify the defense, point it out, ask about it, ask about the impact of the defense, and then challenge the defenses by blocking or interrupting the defense, pointing out the components of it. Some parts of defense can be the way they hold their body, the way they cover with a smile. By pointing them out, by blocking and challenging these defenses, it causes the feelings to go to a higher level. So again, we have here pressure that mobilizes the feelings, anxiety, and defense, these triple factors. The defenses go up, you clarify and challenge the defenses. Then the feelings are felt here, dropping the anxiety and opening the unconscious things. So I think we should move ourselves on, at least start to talk about the main case here and what our main job here, which is fragile character structure patients. They've had absence of secure attachment and haven't had parents with anxiety tolerance. So parents with fragility typically, and they have cognitive disruption and primitive defenses, and they need capacity building. So it looks like this. There's a non-secure bond, ton of trauma, primitive rage and guilt, and then fragmentation and other symptoms and self-destructiveness kick in. They can suffer in multiple ways into, any of these patterns they can be stuck in at some points under the heavy burden of the guilty rage. Stuck in major dissociative, social isolation, huge somatic problems, sadomasochism, drug dependence, major economic problems, massive anxiety, get into criminal activities. So there's a spectrum of fragility. What's going on? Okay, so the spectrum of fragility, we're going to spend our time going from mostly like here over. So on one end of the fragile spectrum, we have severe fragility where there's at a low level, the person uses projective processes and splitting, and they have very little ability to be tense and intellectualized like the patient I just showed. So without much mobilizing, they're into big difficulties here. And a lot of dissociation and cognitive disruption can be there. And sometimes a lot of repressive process, stomach upset and other things can be there. When you get over to moderate fragile, the person can hold some rise, some tension and some ability to reflect before falling into all these things. And mild fragile, they can hold almost to mid-rise before they run into major troubles. So here's another way I'm representing it these days is sort of separated parts, if you like, and I'm using the word parts meaning characteristic patterns of behavior that they tend to stick into or see other people stuck into. For example, critic, hostile critic. They can get in hostile critic. They can perceive you to be hostile critic or someone else to be hostile critic. Victim of hostile critic, okay? Can be another one. They can be in it. They can perceive you in it. We're going to talk about this here. I refer to these as modes of operation that they see people stuck in and they get stuck in. None of them are whole. They're all sort of partial features of a person, like they're not like a whole person. Then versus just regular projection, for example, sit there and think you're angry, that you have anger, but they have anger, and the projective process. And we've talked about these other ones here. Another way to think of it is, what are they doing? What can they do? So hierarchically at the top, when the anxiety is high, they're going to be doing these things. And when it's low and going over here, they can do it, isolate affect and have repression. So there's another, I'm trying in different ways of trying to represent this. Now, another piece here is that the maximum UTA, unconscious therapeutic alliance, the person can use. When they're at this level of fragility way down here, they can't tolerate feelings at all. If they have a positive split second with you, the rage and guilt and grief come up after the positive with you, and they cause a major disruption up here. It causes all this projective processes and splitting and everything else to kick in. They don't have any UTA at that point, at this low level. When they get more over to here, they can hold a bit of positive feeling and a bit of grief, but the rage and guilt shoot over a threshold into confusion, into projection, into split parts, into all this stuff. They might be able to put some things together, be able to link some things and understand some things, with be able to, like something I call whisper from the alliance, where they can connect some things, but that's all they can do. When they get further over, they can feel a bit of the rage and a bit of grief and positive, but the guilt shoots into all these disturbances up here. And at that point, they can do negation. And they can tolerate a bit more intense focus from us. And that's a sign that things are going better. Yeah. And when you get way over to here where they don't have a threshold anymore, the feelings start to break through. Okay, so we want to get over here where they have a high threshold. These phenomena, and I'm going to really detail this so you have a map and you can see these things move. It gives you confidence that you're going in a good direction. And that's part of why I want to detail in this course, to help you see the little things that are happening that are adding up to benefits, so you don't get discouraged and you can see a pathway ahead. So this is just another way again to say it, that quickly down here, they shoot into split parts, here to projection, here to disruption. It goes along the capacity levels here. And we're going to watch this stuff go through. Some patients at some points in this fragile and repression, they have quick rotation between projection, repress, self-attack, and confusion. So they flip between these different positions very quickly. And that can happen within seconds. Go from projection to sick in the stomach to confusion to self-attack in some way. And this happens, can happen all the way up the threshold as the capacity is being built. They can flip. Another process that can happen is self-escalation, where the person projects something, reacts to it with fear and then rage, and then guilt about the rage causes it to make more projection. So the guilt makes projection, the projection makes more rage, makes guilt, makes projection, spins around until the person can be in a paranoid state of projection called psychosis, going to the hospital hallucinating, can be into severe repression, body depressed symptoms and such, or paranoia, or violent. And this can happen under an escalation. And we're going to talk about this. She has some of those cycles, and her life's work in the 20 weeks of this treatment becomes mastering the understanding of her cycles and her patterns. That's her job. So what do you have then? You have in fragile character structure, FCS, you have capacity building and then other phases, repeated unlocking, working through termination. And when you start with this patient, what you see is this: they have feelings, yeah, they have unconscious anxiety, and there are defenses, but these are not linked that they can see. They don't understand that there's a connection between these things. So this just seems to come out of the blue. These can come out of the blue. Feelings can pop up out of nowhere, and they're not connected. So it's a disintegrated structure that needs to become solid. And we're going to talk about the changes on the triangle. So the other broad way to think about it is two big phases you can think about. One is stabilizing and psychic integration. And then the next is graded format, which in my books starts somewhere when they have moderate capacity, moderate fragility, they can do graded work. Before that, it's sort of like a person struggling to understand some of the basic things going on inside, and needing some structure, something to hold on to. And so psychic integration is building the early reflective capacity, overcoming projection and impulsivity. It might be up to 25 sessions. So, I'm talking about what 20 session time limited. You do what you can in 20 sessions. Versus graded format. They can do some UTA, some breakthroughs start to happen, and they get more muscle tension and isolate affect. But first, this is what we're going to be into. So think about it as this part here, because there's so much going on up here. It's another way to think about it. You have a person that's like struggling to, on the ocean. They're drowning on the ocean. They need to start to be able to float a little bit before, and then they need to be able to have something to float on, like a raft, before they have a platform stuck to the ocean floor to start to feel an emotion. Before they can have a base, they need something to hold on to. And the structures of doing that, I think of them as this. These are the sticks that make the raft. Feelings make anxiety. Feelings make defense. Anxiety makes defense. Past and current are linked. All these linkages. Bond makes fear of separation. Separation makes fear and grief. Grief makes rage. Rage makes guilt. Split parts inside are the same as split parts outside, current, etc. These links and connecting these things together, to me, are the sticks of the raft, that they can see some things make sense and connect to other things and intellectualize about it, and you're connecting various regions. And when you do that, you end up with a person who can be better integrated on be able to better reflect, settle, and observe. So this is just saying the same thing here, linking things together. Help them work with projection, help them work on any modes or split parts, observe body responses, label phenomena, build a self-reflective integrated structure, and then you get them to moderate fragility, and then you can do graded work that we'll talk about when we get there. So think of it this way. You got the drowning person, you start throwing some sticks to them. They got a bunch of sticks they can hold on to so they're not drowning anymore. They bundle together the sticks of the knowledge of the links and such, then they get a raft. If you get that done in 20 sessions, you're quite happy. If they can float better and not always drowning, okay? So, and these, again, the sticks are, this is, connecting one thing to another thing, one thing to another thing. These things are similar in some ways, you can pair these things, So you do things with the informational links. And you got to handle projection. So projection, so you got to be able to detect it. And projection in a fragile patient, I think hardcore projection, a big P projection, the person is afraid of you, or for example, they back away their chair, they're shaking, they're scared, okay? Or they're counter-reacting with anger to you because they perceive you as a threat. These are examples of when projection is significantly strong operating. And how do you work with it? You can ask them how they view you, how they think, how they think you feel. Ask them to reflect on the thoughts that are coming up. Ask them where the idea comes from that you would do that, or that you would, behave that way. Ask them where, their life experience that comes up. In a way, I did that with her. You see, I said, so when you were in the hospital before, that was very stressful. So when you're coming in again, that brings up some things from the past. Do you understand? I'm doing the work because she's in my office thinking I'm going to do things to her. That's coming up from the past. Another thing here is regulate down the anxiety, label the anxiety, help them recognize their body is anxious and that causes projection to kick in. So that helps them. You can counter a projection, behave differently than a projection. So that's another approach. You're going to see me do all these things. You can be present, this distinction from the projection. Speak, be present, say something. In other words, don't be a blank screen when a person's stuck with a projection. Be yourself, present, and that works against projection. Now you start monitoring, and the anxiety is then going to go into cognitive disruption. When you have handled projection, it makes anxiety shift into cognitive disruption, typically where they get fuzzy. That's when you know projection has now been weakened or cut through. Now they're drifty. Now they trust you. Now do a little recap, help them settle their body down after when they're fuzzy. Okay? So there's some steps there. We'll go over this in some detail. Okay. So to get to the place where they can have tension and intellectualize and self-reflect and tolerate rises in anxiety, we have to really help them reflect on all these things, and we have to counter the tendency to dissociate, to split, and to repress. So we have to help them observe those processes and help them not do those processes. Now, you can say there's two big processes. One is graded format, which we really haven't seen. We've seen a little bit of it. We've seen me try to do graded format where you have cycles of pressure and then recap, or pressure and recap. But before that, it really involves, the process is psychic integration to help the person overcome the splitting and projecting parts of themselves outward and interacting between parts of themselves in splits, to make that an integrated structure with anxiety mostly, and with some tendency to repression and anxiety to move this way. From here, you can start to do graded format. Now, you see me try to do graded format with a person who is still using too much split parts. And today we're going to move just to the next session, session 3, to see the more formal work on the split parts and this process, which I refer to as modes. One mode being critic, one mode being rescuer, one mode being victim, and then projecting those out and interacting with them in other people and interacting within themselves between parts, as if they're separate entities inside of a person, inside or outside. You're going to see that in the video, more talked about more clearly, because as soon as we were trying to do the work of graded format up here, of graded format, when I tried to do that, she was shooting up into split parts, and she couldn't integrate the work of graded format yet. It's too much split up projective processes that you can't yet do graded work. You have to first do the work of helping them see the split parts, connect things together, put sticks into bundles to make a raft before They can really do graded format. So that's what we're going to see first. Remember, the sticks are connections between one thing and another thing. Feelings make anxiety. Feelings make defenses. Attachment brings fear of separation. Rage brings guilt. Split parts inside make split parts outside. These are some of the linkages. And then there's just the knowledge that there are these split parts that never want to be overlapped. And you're going to see the trouble she has when you try to overlap both two split parts. The anxiety shoots up. So that's this work. Help this person see the modes are inside and outside, understand the past origins, see how the modes interact between each other, help them see the split second when one mode shifts to another mode, the overlap between the loving husband and the nasty punisher. Help them hold awareness of the different modes, and it tends to cause drifting. And then gradually, it will tend to move to the rotations more so, the regular rotations. And grading becomes possible. So you can more easily work on, when they just do some self-attack, repression, projection, you can more easily work in graded way with these rotating fronts. Here, up in the split world, you can't work the same way. I hope that you can see that. You got to work in a way to integrate the splits. And this is a way, just when we stopped, I was just summarizing this here cycle that we saw that she has. And as I was recapping on this, there was some tension in her hands. So you see, we're moving ourselves to the point where she can see these things, see these processes, therefore integrate some of the split pieces, overcome some of the tendency to repress, okay? And get to the point where graded format starts to make more sense. And so she starts to look a little bit more, you can see some anxiety, some tone, some smooth muscle. You can see her anxiety more and less of projection and splitting. And you start to see a triangle start to form gradually. And then you can do sort of work building the capacity through that. The obvious gradually answer here is if she can recognize or feel guilt about her rage, it stops the cycle. If she can realize she's the caring, loving person who has guilt about her rage, therefore has built mechanisms to protect people, then she can stop doing everything else. That's the ultimate, is to be able to recognize there's the guilt about the rage. Okay, so we're not there yet, but we're going to be doing more work on that, with the goal being moving across the spectrum. The other thing just to say is, here we are over here. And one of the things with the therapist stance is that, present and engaged. Did I go over this yet?
Yeah.
I made this, I did?
A little bit, yeah.
Validating all things.
Not this whole thing, so.
I just made this today. I made it. So present and engaged, validating things, integrating splits, being ourselves integrated, ourselves. So we're not doing rescue, we're not idealizing, we're not devaluing, we're not self-devaluing, we're not self-idealizing, we're not controlling, we're not submitting to the control of others.
Mm-hmm.
Okay? We're holding in a reflective stance, using our brain to do that and showing them how to do it. And another piece is looking a little bit ahead to the next process. So what I mean by that is, here we are, we're in the integrating process here. And we're looking ahead on what's coming ahead. What's coming ahead is going to be graded format. We're looking ahead when she can be over here. So we're here, but we have a bit of a vision of what's coming next, or what can come next. But the first work was on melding together the splits. And and when you do the bringing together the splits and the projected processes, it causes cognitive disruption at first. And then you move the patient along so that they gradually can have some tension and hold some tension and reflect of the processes above, then you can do graded format. And graded format is when you press up and recap. Press up and recap. Second here. Press up or brace up, and then when they get fuzzy or nauseated, then you recap down. And then when they're solid again, then you press up again. And you gradually mobilize the feelings, and the unconscious alliance gradually comes up. And then you get to the point where they can have first breakthroughs, small unlockings at first, where they can tolerate the feelings at a high enough level that the unconscious alliance comes up, the feelings are felt, and the resistance drops down, and then they can link the content to the past. So one thing we do to build the capacity is what I've called this immersive approach to building capacity, or immersive technique, is you press up and they have a split off rage. So they have a rage on somebody, but it's split. And then you press the guilt in there and the positive feelings in there together. So you make it a complex feeling, and it makes anxiety go into the striated muscle. So you move it over here. So now in that session, you've increased the threshold of anxiety tolerance from this high up to this high. So you've moved it up by doing this immersive technique. The next time they can tolerate a higher rise and hold the mixed feelings at a higher level. Then you do the same repeatedly. So pressing on the guilt as a mechanism to shift the anxiety pathway into voluntary muscle. It's pressure to be integrated. It's also builds reflective ability. It's a statement that when you ask about guilt, it's a statement that you know they're a caring person who doesn't want to do harm. Okay, there's a lot of positives when you press into the guilt. Now, you can only do this, though, effectively and helpfully when they have at least some ability to be tense down here. Like I couldn't do it up here because it's not really guilt that they have. They have split parts that are competing or attacking on one another or opposed, or it's not really a complex feeling that they're having here. But here, it's complex feelings turning to anxiety. You can do graded work, you can do that immersive technique, and you're going to see more of that, or at least some more of that here when we look at the next session. So what you see me do in session is I press up, and they feel some of the rage come up. A second here. Some of the rage, positive grief, rage, and the guilt shoots over into something, either cognitive disruption or projection or nausea. Then I press on the guilt quick. How would you feel if you hurt me? Press the guilt in there. Makes anxiety go in the muscles, and then they're ready for the next rise. So we'll see more of that work. It's one of the most important things that I think I figured out about this. I think it's a real optimizing approach to work with these patients, to be able to work with that. So this one, but with multiple thresholds. So you got positive, grief, rage, guilt. Where are you at? Is there any sign of alliance? The maximum alliance up here. Where are you relative to threshold? What's possible for the person to feel? What's the next hardest thing for them to start to experience? You know, and also the idea of the threshold where you're doing work with this guilt immersion is huge. I mean, these things are like maps, and I hope they, you find them helpful when you look at your own video and say, where are we on this map? The other one is, these are brand new ones I just pulled together that I don't even know if they made it in the slides. These two here. This thing. What are you doing where? You're bringing rise down here, you're dealing with repression here, you're regulating anxiety here, you're handling projection, you're integrating splits at different levels of rise, which means you have different tasks at each of these kind of boxes. related to level of fragility. The other way to think of it is, what's the person doing right now and what do they need? Okay. So, but you can also think about it as far as overall, you know, in the group of sessions you're in, or the patient in front of you, what processes am I going to need to know to use today? Likely. And then you're watching for those things. Okay.